Welcome to Myths, Realities, and Best Practices for Psychiatrists Treating Justice-Involved Populations in Community Care, which will be facilitated by Dr. Deborah Peinels and Dr. Marvin Swartz. We'd like you to take a moment to read our brief disclaimer. As well as take a moment to acknowledge our webinar sponsors, who are Policy Research Associates in Del Mar, New York, and the Substance Abuse and Mental Health Services Administration. As previously stated, our webinar presenters will be Dr. Deborah Peinels, who is a clinical professor of psychiatry and the director of the program in Psychiatry, Law, and Ethics at the University of Michigan. She also serves as the medical director of behavioral health and forensic programs for the Michigan Department of Health and Human Services. As well as our other webinar presenter, Dr. Marvin Swartz, who is a professor and head of the Division of Social and Community at Duke University. We'd like you to take a moment to briefly review the objectives of this webinar. And lastly, we'd like you to acknowledge the origin of this project, which is simply that there is a huge shortage of psychiatrists in the United States, with about 77% of U.S. counties reporting a severe psychiatrist shortage. Similarly, there are fewer than 2/3 of adults who have a severe mental illness that are currently receiving mental health services. And with that, I will send it over to Deb to continue the presentation. Thank you, Deb.
Great. Okay, thank you. I just wanted to say first and foremost, thanks to SAMHSA and to PRA for inviting me to participate in this webinar. Working with justice-involved individuals has been a passion of mine, and helping to develop a workforce and training a workforce to do so is also something that's been critically important in my career as a former training director for forensic psychiatry fellowships and working in these settings, as explained in my introduction. So I hope you'll all get a lot out of this webinar, and we're going to start by talking about the scope of the problem to help you understand the context of why now is a perfect time to be thinking about these issues. First of all, we know that the need is increasing, and as part of the Affordable Care Act, more people were able to receive behavioral health services through their insurance. This has introduced an influx of new patients that we are attending to in a different way who have mental health and substance use disorders. The influx has largely been unable to receive all the treatment options available to them, due in part to a lack of psychiatric resources. And we see this over and over again in all the states. Similarly, as more attention has been focused on jail diversion, which has become more the norm than not, diversion programs have developed. And with these programs, we see an effort to help divert or release justice-involved persons back into the community with a tighter linkage to appropriate services. As a result, the number of justice-involved persons in the community has increased, but also attention on who has justice involvement has increased. And so the justice-involved population is identified as having many behavioral health concerns that may need to be addressed. And similarly, individuals with serious mental illness who have justice histories are also increasingly identified, and their unique combination of needs is one of the things that we are hoping that through webinars like this and other initiatives, a workforce of psychiatrists will be able and willing to work with them and serve and help address these multitude of needs. Also, another issue that we're all dealing with is the opioid crisis, and many counties and jurisdictions have begun to provide treatment resources to assist in combating the crisis. This has introduced many more people to behavioral health services across the country. However, many communities are unable to meet and treat everyone who needs the behavioral health assistance, as the demand outweighs the supply. We're learning more and more also about the co-occurring mental health conditions that go along with opioid use disorders, and we are seeing more of these needs coming to the attention of behavioral health clinics. So there has been further pressure and strain on behavioral health system to identify practices and strategies, including the need for more psychiatrists who are adept at working with individuals who are justice involved to help address any issues related to behavioral dysregulation that could be helped by psychiatric intervention. There is also a supply that's decreasing exponentially, although we may be seeing some slight increase in medical students matching into psychiatry. We're also seeing that psychiatrists are nearing retirement, and fewer early career psychiatrists are pursuing fellowships, including fellowships in forensic psychiatry or work within the public mental health system, whether it's in community mental health or in state hospitals or correctional settings. So while the need is increasing, the supply is decreasing. So this slide is an introduction to what will be a deeper dive of the scope of the problem in relation to the workforce imbalance and what the disincentives or perceived disincentives are, and some of the incentives might be for working with justice-involved individuals. So let's talk a little bit about location of residencies as a start. The number of general psychiatric residencies are seemingly low considering the high demand for psychiatry. There are about 209 general psychiatry residency programs in 48 jurisdictions. This creates a relative psychiatric desert in the Upper Rockies. The situation is heightened when one considers that the neighboring states offer few residency options. There is new information about the creation of a regional psychiatric residency track to serve the Billings, Montana area, and this was created in partnership with the University of Washington and funded by the Helmsley Charitable Trust, which will essentially remove Montana from the psychiatric desert and welcome a change to this area. Nearly half of all psychiatric residency programs are located in 6 states, primarily in the coastal areas, which is another challenge for getting psychiatrists out to those states that have significant needs. Now, when you look at forensic psychiatric fellowships, we see that there are 17 fellowships in psychiatric subspecialties such as rural psychiatry, public and community psychiatries that also might promote engagement with justice-involved persons. In fact, the psychiatric forensic fellowships focus on the area of forensic psychiatry with a growing interest in correctional psychiatry as well. But not all individuals who work with justice-involved populations need to have forensic psychiatry fellowships. In fact, as I stated earlier, there are many opportunities for learning and working in community psychiatry where one will eventually work with justice-involved individuals. And you'll be hearing throughout this webinar from a variety of psychiatric professionals who have various types of training that have led them to work with this population. The 48 programs focused on forensic psychiatry are depicted in this map, but again, there are expansive regional gaps furthering the evidence for psychiatric training deserts, particularly for people who have justice involvement histories where it might be difficult to get some unique forensic psychiatric expertise to help consult on cases. Another issue that we are facing is where psychiatrists tend to practice most. Of the more than 37,000 known active psychiatrists nationwide, nearly half are located in 6 states. Another way to examine the data is to look at per capita rates. This is from Merritt Hawkins citing an AMA master file. Jurisdictions along the eastern seaboard claim per capita distributions of psychiatrists that are 3 times the national average, while states in the Midwest and Upper Rockies have per capita rates well below the national average. About 56% of general psychiatrists practice in the state where they receive their highest degree, and a percentage that is well above the corresponding figure across all physician specialties. The other thing that we know is that even when there is a higher per capita ratio of psychiatrists, such as depicted on this map, many of those psychiatrists are not working in public mental health and are not working with, for example, Medicaid-eligible patients and are not working with justice-involved patients. And therefore, even the per capita ratio doesn't tell the full story for those regions where it may look like there is a greater wealth of psychiatric resources. There's also a disproportionate number of psychiatrists who choose to practice in urban versus rural settings. One of the reasons that we understand this is because of some of the misconceptions related to what it might be like to work between the urban and rural divide. A reasonable assumption is that consumer needs for the psychiatric workforce will be greatest in states that lack GME residencies or fellowships and in rural areas. However, as I said again, even in urban areas, we may see a dearth of psychiatrists choosing to work in public sector settings, which is again why this webinar I think is going to be very helpful for people interested in considering working in this space. In this webinar, we're going to see a number of videos from people who are actually providing psychiatric care and receiving psychiatric care within the context of justice-involved individuals. In this first video, we will see Dr. Grace Lee discuss how many psychiatrists live and work in urban areas, but many justice settings are in rural areas and how this creates large gaps in treatment for those that are justice involved.
Psychiatrists tend to live and work in urban settings, metropolitan areas, but many of the correctional settings, which is where you have can wind up with a large concentration of individuals with mental illness and the criminal justice involvement, are many times sited in rural communities. They can be hours away from the next large city. So the geography becomes a daunting problem.
The next issue that we want to talk about in terms of the scope of the problem is the correctional status. The scope of the problem includes a misperception that working with justice-involved persons can only be done in institutions or correctional settings, such as in jails or prisons. Although in my own personal experience, working in those settings is just as rewarding as working in a community mental health center, it is important for people to realize that most people outside of law enforcement are unaware that justice-involved persons are in the community and may be under correctional supervision, such that working with the justice-involved population also requires some very interesting connections to working with probation or parole, depending on the status of the individual. And that can also be another way of thinking about how working with justice-involved individuals can be interesting in terms of coordinating and collaborating with correctional entities. In the next slide, we introduce what's known as the Sequential Intercept model, which many of the listeners and participants to this webinar may be familiar with. The Sequential Intercept model is simply a means of mapping out the justice system in order to find places where possible identification of individuals with mental health and or substance use disorders could be appropriately diverted into treatment as opposed to further penetrating deeper into the justice system. We use the diversion broadly in this context, although it can have many meanings in different jurisdictions. But jail diversion is a means of decreasing the high rates of incarceration for people who may need treatment for a behavioral health issue, where that's the more appropriate and still safe course of action for those individuals. We're going to look at examples at each intercept in practice. In the first video, you're going to see how, as we flow through the sequential intercept map, Dr. Lee addresses how all justice-involved people came from the community and that they will end up back in the community.
That the criminal justice system, it can be mapped out from arrest to adjudication to sentencing to incarceration, but the two bookends on either side that can't be forgotten are that they all come from the community and most of them are going back to the community.
In this next video, you'll see me, Dr. Carmen McIntyre, and Dr. L.A. Ayoun discuss the type of work done at Intercept 0 and 1. The work includes assessing all aspects of the person's life, including the need for work, social support, and other factors in relation to their treatment needs and diverting people away from the justice system prior to going deeper into it. Likewise, insights on working with law enforcement are discussed.
As I kind of got out of my residency training and moved into my career in more community and public psychiatry. It started off with really providing an integrated treatment team where you were addressing, not just their medication needs, but what were their social skills needs. Did they need housing? Did they need employment? Did they need access to food? Did they need access to benefits and whatnot? And I think that was a great next start. But then when you start talking about diversion or preventing people from getting justice involved in the first place, then you have to start addressing some of these social disparities. You have to start addressing kind of some of the injustice that's out there. And you start talking about primary prevention, which is really kind of before they get through our door.
And the message is a complex message when you work with police because it's about public safety. That's the number one thing that police need to ensure is that the public is safe. But it's also about teaching other strategies and approaches that might help both improve public safety and lead to better outcomes overall for everybody involved. So again, working with the different police officers that I've had the opportunity to work with over the years, I've never done police training without doing it with police and hearing their perspectives.
But also it will decrease incarcerations and involvement with the criminal justice system because as the primary responders get used to this concept of psychiatric crisis services, they'll start bringing folks who have probable mental illness or substance use disorders to the crisis services as opposed to taking them to jail and booking them.
If you want to change how law enforcement is practiced on the field, everyone should get training. And something else they said was that the training they get is very medically oriented. They would learn about schizophrenia and schizoaffective disorder and major depressive disorder and major depressive episode. They're like, we don't care to know about this. What we care to know is we're on the field, we're seeing someone yelling and screaming. We want to know, is this person mentally ill or is this person just acting because they're upset or they're dangerous? Should we take them to a hospital? Should we take them to the precinct? We came up with the idea of creating something that's symptom-based. So the topics that we decided to work on were like agitation, anxiety, sadness. Like instead of saying depression, we used words that the officers could relate to, like sadness. And we decided to create online modules that would be easily accessible, that would be easily understandable. So we weren't trying to tell them about the most up-to-date research about the treatment of schizophrenia, whether this antipsychotic medication is better than that antipsychotic medication. But we wanted to tell them this is what someone who's psychotic is likely to look like. And if you see someone like this on the street, the behaviors you're seeing might be caused by a mental illness, or might be caused by a drug overdose, or it might be caused by a drug withdrawal. And this is an emergency situation that requires something to be done on the field, while this is something that requires treatment in a hospital. And this is not necessarily something that needs treatment in a hospital. This is someone that needs to be dealt with using the normal police protocols.
In the next video, we're going to see Drs. Trustman, McIntyre, and Lang discuss the type of work they do as psychiatrists at Intercepts 2 and 3. Along this line, some of the differences between medical and judicial terminology will be discussed, ways in which psychiatrists work collaboratively with judges to help explain and become interpreters for judges in working in partnership with them, and the role that psychiatry can play in court proceedings as well as work within correctional settings.
We have, as psychiatrists, a wonderful opportunity to respectfully educate judges and the staff of the court in ways that would allow them to better provide options to incarceration for our patients. And so there is a give and take in this process, because all too often in most of our communities, there are not adequate alternatives to incarceration. A judge might want to be able to defer incarceration and refer someone to a treatment program, but it may not exist. And so for me, it's been wonderful working with judges who are interested in this area and helping them understand both the language. We each speak very different languages in law and in medicine. And so helping us bridge those gaps to understand the opportunities for treatment, the needs for treatment, the challenges of relapse as part of the illness, of drug abuse or of severe mental illness, has led to wonderful, transformative initiatives in different courts around the country.
So one of the nice things about just people in general starting to think more about diverting people with mental illness from jail and prison is that we started talking more about the sequential Intercept model. And there are a couple of different ways that Intercept 2 can play out. It might be a regular court system, but the judge recognizes that there are issues around behavioral health. It's a severe and persistent mental illness. This is trauma-related, somebody who's in an abusive situation, for example, or this is substance use disorder related. So they can choose to have the person go into treatment before getting to the point of conviction. So it's like, let's give this a try, let's see, let's get you assessed, and then yes, you have something that needs to be treated, so let's get you treated. And if you're compliant with that, then we don't proceed along this path that leads to prison.
I work primarily at the Allegheny County Jail, and we have something kind of unique there called the Behavior Assessment Unit. And what that entails is performing evaluations for inmates that have been arrested and come into jail, and we're assessing their competency to stand trial, making sure that they're not getting taken advantage of by the legal system due to their mental health. In my role, we kind of oversee those evaluations, go into the jail, talk to people, make sure they understand, and then on the flip side, we'll bring those results to the courtroom and kind of tell the judges what's going on, whether the people understand it or not, and whether or not they would need any treatment further to help them regain that competence.
In this next video, we'll hear about some work that psychiatrists do in Intercepts 4 and 5.
I've been working also in reentry activities in Massachusetts and Michigan and had the opportunity to see how reentry works in both those states. In Massachusetts, I was responsible for something called the Forensic Transition Team. They were assigned to identify people with serious and persistent mental illness. They would do in-reach activities where they would work with the individuals to help develop a release plan with the supports that they would need upon re-entry into the community, and then tracking them for a period of time into the community to make sure that there was a handoff to the community provider system. In Michigan, I've been working with reentry through the State Targeted Response Grant related to the opioid use disorder. And that's, again, where we have a case manager and a peer linked together to do 3 months of in-reach and then 6 months of post-release follow-up, targeting people with opioid use disorders who have co-occurring mental health conditions and providing them, again, the supports that they need in the community. My experience in both those programs, obviously I had more years so far in the Massachusetts program, and the Michigan one is relatively new. But the reentry space is really interesting to me. Having the behavioral health community come in and do reentry work creates the need to learn a whole new culture and a whole new language. And similarly, for the correctional side, to work with the behavioral health community, it's a whole new, cultural experience is brought to them.
As we think about sort of the perceived disincentives for working with justice-involved individuals, we wanted to break down some of the other thoughts that people have shared with us as some of the reasons why it may not seem to be the right type of workspace or the right type of population to work with. And so we want to discuss what perceived disincentives are and then hopefully do some myth busting as we go through the webinar. So in this video, in the next video, I and Dr. Lee will address some of these negative misperceptions in relation to the justice-involved population as a whole, as well as the stigma that is sometimes attached to the psychiatrists who work with them.
Actually, the disincentives seem overwhelming before you start working with that population.
Sometimes early career psychiatrists or psychiatrists in training, they have a certain degree of awareness that it's a problem, that they should be interested in it, but they might have misconceptions about what it's like to work with those individuals.
I talked to colleagues and said I was considering working in a women's prison, and colleagues told me, why would you want to work with that population? They're difficult to treat. They have personality challenges and life challenges that are going to make it just not a rewarding part of your career.
There's a lot of media attention, there's a lot of press out there about individuals with mental illness who are incarcerated, about how they're arrested or managed in the criminal justice system. So there's this awareness that there is this group of individuals out there with mental illness, that there is this field.
The fear factor that many people have about working with this population, or the distaste for working with the population. You meet people where they're at, you start seeing them as people, as we do with all of our patients. Everybody's got their stories that they come in with, and you start understanding them more as you understand them as people. So the distaste for the population is really not founded, in my opinion.
The stigma that's associated with being an individual with criminal justice history is something that not just lay people are vulnerable to perceiving, but also, psychiatrists as people as well, not really knowing what those individuals like or what they need. And then there's also that issue with the stigma that can attach to those people who work with individuals with criminal justice histories or in criminal justice settings.
There's also the concerns about safety. On the whole, that's one of the largest barriers, we think, for having individuals, psychiatrists work with this population, is this belief that the population is violent and that the settings in which psychiatrists would be practicing would be unsafe. The clips that we're going to show, the video clips, address this myth, and then the realities of the population really not being any more violent than people in the community, and that if you do work in an institutional setting, you may actually perceive greater safety than in other settings. In this video, we look at some of these common myths with Drs. Metzner, Lang, Ayoun, McIntyre, and myself talking about some of these perceived disincentives.
One of the issues that I frequently hear from early career psychiatrists is their concerns about it being a dangerous environment to work in.
You're working with a population that has charges of serious nature against them.
A lot of people who train in medicine have a lot of resistance to the idea of working with the criminal justice involved population, and they think of potential for dangerousness, that they're worried about going to prisons, even though, the research finds that people who work in correctional systems have the safest jobs among physicians.
Oftentimes, I felt safer working in some of the correctional settings that I was in than I did in other settings that I've worked in, where there hasn't been as much protection around.
It's not a significantly dangerous environment compared to other environments. That's why you have correctional officers, or deputies, as they're called in many jails.
You're in a very secure setting. You have a lot of support around you. You have correctional officers, you have guards, you have counselors, therapists, social workers.
Corrections officers, court officials, etc., they're taught the same kind of de-escalating or de-escalation techniques. And, quite frankly, folks in corrections, whether it's in court systems, it's in jails, it's in prisons, they have a lot of experience dealing with folks once they become agitated. When I'm working with folks that are mentally ill and could potentially become violent, I'm safer if they're around and if they're part of the team than if I'm on my own in an outpatient setting or, on an inpatient unit.
The third perceived disincentive is the belief that the population has different and more complex clinical needs, making it difficult, if not impossible, to treat them. And so it's often a concern of colleagues who hear that you're going to be working with justice-involved individuals to say, but are they really people that you can help? And that is really somewhere one of the myths that needs some correction, because the people that are just involved can be helped in many ways similar to those that you see in the community, because they really are the same sorts of people. You're just seeing them at different points in their illness and in different environments. So they're individuals with similar mental health needs. The knowledge that they are justice involved or potentially going to be incarcerated or are incarcerated can affect how people interact with them. But if we look back and peel the layers of the onion back and see them as just individuals with their own unique set of health concerns and mental health concerns and substance use treatment needs, we can perhaps do better at dispelling some of these perceived disincentives. So in this video, you're going to hear the idea about some of these misunderstandings through Drs. Lee, Dr. Trustman, and myself. And we'll discuss how the clinical needs of justice-involved people can be the same as those as clients in the community. And they are already often being treated similar to how they are within the community practices in terms of access to care. But our roles can also be to advocate for the care that they need.
There's a tendency for those who don't have forensic experience or forensic training to somehow start to think that the criminal justice population, the justice-involved patients, are off in a different universe almost, that they don't understand them, and they also don't potentially need to worry about needing to understand them because they won't need to interact with them. But I think that that's, what's important for everyone to understand is that that's not literally true.
The people that are justice involved are the same people that they might see in an emergency room. They're the same people that they might see on an inpatient psychiatric unit. They're just seeing them at a different part of their life and of their life journey. We know with the high rates of justice involvement for people with serious mental illness that if you're going to take care of somebody with serious mental illness, you're going to encounter somebody that has been through the justice system.
Individuals with criminal justice histories are people like any other people. Their mental health needs are very similar in many ways to the patients they already know.
It was one of those aha moments when I realized that these were exactly the same people I had been caring for over the last 20 years, just at different points in the arc of their lives. These were people who previously I had seen prior to becoming addicted to substances and becoming justice involved. These were people who I had seen who had been manic, had been incarcerated, then were discharged, and I was treating them a year later when they were back in the community.
Our fourth disincentive is that of financial compensation. It's no secret that psychiatry is among the physician specialties that does not receive the highest compensation rate on average. Here you see some national data presented to you. And although psychiatry compensation is certainly high enough to live well, when one thinks about going into psychiatry in the first place, comparing the compensation one could receive if one chose a different specialty in medicine, it does make for a choice that has created the need to encourage medical students to see psychiatry as a worthy profession, despite the differential in the compensation overall. In this data set, you see how the compensation averages out for certain types of psychiatrists working in the public system. This probably reflects forensic psychiatrists who, again, are salaried within the public system as opposed to working in a private practice. And again, that's one of our challenges in thinking about psychiatrists working with public patients, is that the financial benefits for working in a private practice is higher often than those for working within community mental health settings or within public forensic settings. And so therefore, this issue of financial compensation is a real one. Several states are trying to work in the area of physician loan repayment, and there's efforts to look at those issues. There's efforts to look at how to improve salaries so that recruitment of psychiatrists can continue in a positive direction. But right now, that is one of the perceived disincentives for working within this space. There are, again, it's important to think about that there are many settings that psychiatrists can work in and work with justice-involved persons. You're hearing from different professionals who have chosen to practice in jails and prisons, some in hospitals, whether it's private acute psychiatric hospitals or public state hospitals, who work at the interface with courts and work in community care practices, or even those psychiatrists who could work in the space where they're partnering more closely with probation or parole, for example, through treatment courts. So there's many different options for working with justice-involved individuals, and the settings can be varied. And so through these experiences, we learn more about how to work with those populations and some of the benefits of working with them. From this point forward, I'm going to turn this over to my colleague, Dr. Swartz, who was introduced earlier on. And I think he and I exemplify these different roles that we've each played in the settings, with me more as a forensic psychiatrist, Dr. Swartz working largely in the field of community psychiatry, and then working with justice-involved in populations and in settings as a community psychiatrist. I think Dr. Swartz has terrific insights into this, and he will take this webinar forward as we look at other areas where perhaps the disincentives can be counterbalanced by incentives.
Yeah, thank you very much. And it's my happy task to talk about some of the positive incentives to working with this population. But I did want to emphasize one of the points that Deb made earlier, and that is that forensic training is not, by and large, required for this kind of work. And often folks who have an interest in community psychiatry and working with disenfranchised individuals are drawn to this work. And sometimes it's not full-time work. It's part of a range of activities that people engage in. And so for many, I think for many early career psychiatrists, it can start out as a part-time job that can expand or contract depending on their interests. So let's get into some of the incentives for recruitment and retention of trainees and early career psychiatrists. So an aspect of working with justice-involved persons that really is an incentive is that it's very intellectually stimulating work. I can recall when I worked in North Carolina prisons that some of the most challenging diagnostic challenges I found in the prison. They're very complex people with fascinating psychopathology. And it was also stimulating, and is stimulating, to have the opportunity to work with justice system personnel and trying to navigate and negotiate how to provide the best treatment possible within the resources available. It's also an opportunity to work with and learn about social determinants and how they affect treating justice-involved persons. And the sorts of determinants we're talking about are poverty, cultural norms, racism, sexism, geography, social isolation, dealing with the legal consequences for their acts, and then largely extensive trauma and multi-generational trauma that's also a consideration working with this population. One of the benefits to working with this population, although not maybe something of choice to the patient, is that they tend to have longer stays, and so there's an opportunity to try to dig in and to affect meaningful change in a longer, what we'd call length of stay in the private side. So in this video, several psychiatrists will discuss a number of exciting opportunities involved in treating justice people. Some of these include seeing meaningful change in recovering clients, as well as cross-field knowledge and collaborative work with the judicial system. Likewise, the ability to impart change in a population of people that are frequently underserved can also be a great pleasure and reward. And in these clips, we'll see Matthew Lang, Jeffrey Metzner, Robert Tressman, Carmen McIntyre, and Ellie Eon talk about some of these incentives. So let's see the clip.
It's very rewarding. The work that I do there is mixed as far as I get a little bit of treatment, I have a little bit of intellectual pursuits, some academic, and I get some challenging work like testifying in court that is something unusual for me. I find that very challenging and very intellectually stimulating.
A jail setting gives you an opportunity to do some long-term treatment for the detainees who are there for many months that you don't get to do in many practices. And the advantage of being able to do some long-term treatment is you actually get to see people change. And in a community mental health center, you may see people after 3 months and think that they're treatment resistant and they don't get better and you stop seeing them.
All too often we see people only intermittently in short episodes, or we may see them once every 3 or 4 months. That's not some context that allows us to genuinely support meaningful change in our patients' lives.
What you can see in a longer-term setting, people who ordinarily you would think were treatment resistant 6 months, 12 months, or even 18 months later show significant improvement that you would have never been able to see.
One of the opportunities in correctional settings or in other justice-involved settings is that we get to see them on a regular basis. We get much more information about them. We have a genuine and much more rich understanding of the challenges, their limitations, and their actual responses to treatment.
It is a population that's typically going to be involved in healthcare for a long period of time, so that you get to treat them to the point where they improve. You get to treat them to the point of recovery.
I think one of the big frustrations that some of the trainees and medical students may have about psychiatry is it doesn't have the same kind of win factor that some of the other specialties do, where you get to fix the bone and sew up the leg and see the person walking again. But I think working in the justice-related field has provided some of that for me, which is great. You get some of that win sense in the fact that working in the justice field gives you access to some tools and the legal system, whereas working in a clinical setting may not have those same tools.
The fact that you're able to kind of cause change, and this change is not only going to affect the people when they're in prison, but it's going to have consequences that will help them have healthier lives and be less likely to engage in criminal recidivism and less likely to come back to the criminal justice system. Being able to affect change like this is very rewarding. We
have so many kind of societal injustices, inequities in access to health care, that in justice-involved systems we have a disparity. We have an overrepresentation of minorities, of the poor, and people with mental health and substance use disorders.
The more I talked with people who were actively justice-involved, I realized that so many of them never had a chance to lead the kind of life I had an opportunity to live. They grew up in horribly distorted family settings, violent environments with a great deal of abuse, neglect, and trauma was a day-to-day experience. And so if we were ever going to try to make a society that could genuinely see itself as giving everyone a fair chance at a good life, then we really needed to make a difference in the lives of the people who were cheated of those opportunities and to try to give some chance to them by treating them appropriately, treating their illnesses, so that they stood a decent chance of leading a satisfying life and beginning to develop the intrinsic qualities that they had and never had an opportunity to.
So by being a psychiatrist working in that field, you get to actively be involved in righting some wrongs and assuring that there's quality of care to a disenfranchised population that really hasn't had access to that.
The advantage of being a mental health professional in the jail is you can help change that. And the reason you can help change that is when you do make that change, it makes life easier not only for the detainees, but it also makes life easier for the deputies and the correctional officers. And once they see that, they're going to welcome your input in changing the environment.
We can see 10, 20, 30 patients per day, but if we work with the legal system, if we work with the legal framework of the criminal justice system, we could actually change the lives of thousands of people.
The third thing that is rewarding is you get to see psychopathology that you ordinarily don't see. And so from a professional perspective, it's very interesting.
You get to see such a broad spectrum of illnesses and presentations to the illness. You get to work with interdisciplinary teams. You get to introduce pilots of evidence-based practice. You're going to see everything. Everything. In a correction setting, you'll see stuff that you've never seen before.
There really are significant personal rewards for working with justice-involved persons. And one of the largest is having the opportunity to make a substantial impact on individuals. And as we've mentioned, despite the misperception that the justice-involved population is not able to recover and are therefore very frustrating to work with, often this is really not the case, and the population is largely accepting of treatment and grateful for the services we provide. In the next video clip, we're going to talk a little bit about the need for personal satisfaction when choosing a career, or at least a direction, and the video provides a lens into several psychiatrists' personal satisfaction with having chosen this kind of work. We'll also hear from Faye Owens, a remarkable woman with lived experience with the justice system and psychiatric treatment, and hear a little bit about how she greatly benefited from services provided in that setting.
The detainees generally are very appreciative of receiving medical and mental health help. They're frequently not very used to being treated in a respectful fashion. So if you treat people in a respectful fashion and, in fact, help them, they're very appreciative clients. And it's rewarding to see not only that they're appreciative, but that you're helping them and that they get better.
The work I've done in developing this kind of psychotherapy to help people who are justice involved to better manage their lives, their emotions, to be able to focus on their future goals and aspirations has been incredibly satisfying and one of the most rewarding things I've had the pleasure to do.
Oh, it's absolutely personally rewarding. I mean, I can think of patients that I saw when I worked in the women's prison or when I worked in a clinic for mentally disordered offenders, and I can still remember the patients that I saw and the relationships that I was able to build. And a lot of them really didn't have experience with relationships, positive relationships in their lives. A lot of them had very traumatic histories, and in working with them and giving of myself, and feeling like I could do something, even though their needs were sort of endless needs, I really felt like that relationship made a difference. For me personally, it helped me grow as they were growing as well.
I think that psychiatrists that work with justice-involved people need to just know them as people. If you just see people for people, take the justice involvement out. Take the mental health out. Take all that out. We're people. Somebody put a hand down for me and pulled me up. Do that for the people. They're gonna be on an amazing road trip. I suggest they buckle in because everybody's not gonna be as sweet as me, but it's definitely gonna be worth it.
So you've heard a little bit about some of the potential impact our services can have on the people we work with in justice settings. And in this next section, Dr. Lee and Pinels will delve a bit into some of the treatment stories that have made a lasting impression on them and move them to continue to work with justice-involved populations.
He's a young man with a somewhat varied criminal justice history, some drug sale, a little bit of assault, a few arrests under his belt already, but also an undisputed history of schizophrenia, and something that won't be unfamiliar to just about any clinician, a spotty history of taking his medication and keeping up with treatment. So this young man did not do well once he was arrested, and at the jail he withdrew. He didn't take medication. He, quite frankly, didn't take care of himself. He didn't communicate. He didn't do much of anything. By the time he came to the hospital, he was seriously underweight. And in the prison side, they would have to be making decisions about what to do with him in a fairly short period of time. So knowing this patient, my assumption would be that he would tell a new set of clinicians exactly what he told us, which was everything was fine, he had no problems, he was absolutely okay, and he was ready to go home. The problem is that that's also exactly the same thing he said when he first came in, when he was seriously underweight, withdrawn, internally preoccupied, not doing well, and his recovery had really only just begun. So what I did at that point was I reached out to the clinicians in the next system. I gave them a clinical summary and shared my concerns. And I heard later on that when he reached them, they decided to not allow him to go to the community, but instead to be hospitalized. So he was sent into the state hospital system. Lo and behold, as I'm going to my new job, I run into him on the street. And this is maybe half a year later. He said, you know, when I went upstate to prison, they said I wasn't ready to go home. And I thought for a second he was going to tell me how angry he was, that maybe he'd heard that I told him he wasn't ready or something. But that wasn't what he said. Instead, he just kind of went on. He said, you know, so I went to the hospital, and I stayed there for a while. And I had to take my meds, and then I got better, and now I'm home, and I'm going to a job interview. So that was quite something. That's all he said. He said it all in a rush, and then he walked off. It's a reminder that as clinicians, we can all make a difference, even if it's just for a little while. It almost doesn't matter, I have no idea where he is, almost doesn't matter how it turned out in the end. Because nowadays, when I see a patient with that kind of history, and I've seen that they made it out, they did well for a while, and they slipped back, that's okay. We know that they can turn it around. And maybe it's a couple steps forward and a step back, but it'll be another couple steps forward. And so the other thing that I really appreciated about the fact that he took the time to say anything is that it also let me know that he appreciated what people had done for him. There was some awareness, I think, on his part that a lot of people had tried to take care of him and had gotten him to where he'd been and were trying to help him reach some other goal for himself. I'm really hoping that psychiatrists who are trying to figure out what they want to do, that they stop and consider this kind of work as something that's important and fulfilling and also very meaningful to somebody else.
The two stories of patient care that inspired me most when I was a resident were cases of individuals, one of whom I treated throughout my residency. He was a man with very serious mental illness and had his psychotic break while he was getting his PhD. This man's journey took him to Bridgewater State Hospital. During the time of his psychotic break, he became quite paranoid, had exhibited symptoms and had engaged in behavior that got to the attention of police. And he ultimately went for an evaluation of his competence to stand trial on criminal responsibility. This was way before I started working with him. This was in his history. By the time I saw him, he was homeless, very psychotic, hadn't really stuck in treatment easily. And I got assigned to take on his case. And I worked with him for 3 years throughout my residency. And he came to his appointments. We developed a connection. I put him on medications. I put him on clozapine, which seemed to help quell his thought disorganization to a certain extent. He was able to get attached to a housing unit and really became somebody who lived with his mental illness in the best way possible. But the relationship that he was able to build in the treatment alliance that I felt accomplish to the point that as I was leaving my residency, we had had our last session, and he came back and he was very disorganized and it was hard sometimes to understand what he was saying, but he knocked on my door and he said, "Can I borrow some dollars so that I can buy you flowers to thank you?" And, he was a justice-involved person in his life, and his life just took a path that he hadn't expected. And that story just really was a patient care story that lives with me to this day.
So some of the biggest advocates for our work are actually people with lived experience that have benefited from our practice. Some of the stories you'll hear now are from people with lived experience who were positively impacted by psychiatrists and are enormously grateful for having the opportunity to receive the services. Similarly, psychiatrists can play a role in helping a client set up other aspects of their life, as you'll see in the video. They can encourage a client to go back to school. They can help them find and sustain both housing and employment. In the next video, you'll hear from Mr. Ralph Correa, Ms. Jeanette Toledo, Faye Owens, and Mr. Davon Harris, who are all peer advocates. They'll provide us with a brief understanding of how receiving treatment from psychiatrists help change their lives for the better.
Well, I would say is to work with your patient, your client, and let them know that they could achieve something in the world that, like me, just because they are diagnosed with whatever diagnosis they are with, that's just a diagnosis, that they are somebody in this world and they could achieve the goals that they are looking forward to do.
When you have a psychiatrist that believes in you, that changes your whole perspective on your outcome, on how you're going to help yourself. And that's what happened to me. When the psychiatrist treated me like a human being, and he didn't treat me like a diagnosis, he didn't treat me like a number or a chart, like a illness. He treated me like a human being, like a mother, like a woman, and like a person and a human being. That's when I opened up and I was willing to accept the help, because acceptance is very important when it comes to mental illness and recovery. So if the psychiatrist could understand that recovery is possible, because for some reason they feel that recovery is not possible. Recovery is possible. If they have the patience and they listen and they could understand that with patience, active listening, there could be a connection there. If you believe in us, like that doctor believed in me and took the time out to really understand.
So I got to see who Faye is. Like, I'm really amazing. Like, I'm intelligent. I'm diagnosed. I am not my diagnose. I'm productive. I'm old as dirt, but I'm passionate. I'm amazing. Like, I'm humbled, right, by my experience of having the opportunity to help people like me. Like, I had no clue that I was capable of taking my life experience and instilling hope in people. That is not what I was signing up for. Like, I was not aspiring to be this. And I'm forever grateful to my psychiatrists, to God, to people that are in my life. Like, I'm trying to find the right words so that you get me. People see stuff in me that I don't see. I've been told that there's an aura that comes off of me that invites people to actually just stop and talk to me. Like, people in the street, I have my headphones in my ear, I'm vibing, I got this little mean face because I don't want you to say nothing. And people will stop me in the midst of that and drop some stuff on me to seek advice. And I didn't know that was in me. So yeah, my psychiatrist has unleashed this amazing woman that, in spite of her mental health, is productive.
When I was released, I went to a three-quarter house. It's like a shelter. And then I was from there here, where I'm at now, where it's Heartshare St. Vincent Supportive Housing. And I got a new psychiatrist, which my diagnosis changed. At CCM, Community Counseling Meditation Services, the psychiatrist there was more different. I had a few of them, but they were like more positive about me. They will give me compliments like, Ralph, you could do this. You are diagnosed with an illness. That doesn't mean who you are. And that brought me to the state of mind that I could do something. My new psychiatrist now, she's awesome. She also tells me that I could become what I'm training now as a peer advocate, which I have an award of RAP. I'm very happy about that. I graduated with my GED and everything because of these psychiatrists that I dealt with at CCM in a different level. Like positive talking to me, like, you could do this. Just because you are diagnosed with PTSD doesn't mean that's who you are. And that put me to think. It really did. And as I see my life changing and evolving in a flower, like a rose, it's like, wow. And I'm like more, I want to go see my psychiatrist. I want to tell her the good news. It's just an awesome thing just to see someone flourish, and other people, my family members, is like, wow, Ralph. And I'm like, yeah, I'm doing it. 13 years now. It's a struggle going, but the positive input I have at my therapy place with my psychiatrist, and it's just awesome.
It was a great experience, I can say. She continued the medication that Kirby Forensic had me on, but she gave me the same level of treatment. Unlike Rikers Island, she actually came to the problem, talked, tried to find the root of my psychosis. She believed it was polysubstance abuse in the beginning, and then she believed it became reoccurring trauma from other events in my life. And she basically properly assessed the issue. I met a really awesome psychiatrist when I came home from prison. She connected me to education. She inspired me to go back to school. She inspired me to do a lot of things. While there, I went back to community college. She inspired me to search for employment. I found jobs. I'm in the process of obtaining a more secure job at this moment. She got me housing through her program. Well, I'm living in permanent housing. She got me into community college. Now I'm at NYU. A lot of people who are mentally ill are just victims of the justice system. I wouldn't say victims, caught up in the justice system, period. A lot of these people, unfortunately, they've been placed in an environment with bad conditions, and so they get a bad stigma. People think, oh, these people are dangerous, or they're unable to be worked with, or they're just going to keep doing the same thing over and over. When one person can come in, like a psychiatrist or a therapist or a social worker, but particularly for me, it was a group of several psychiatrists and one or two therapists. You come into that person's life and you can inspire them, and you can change them, and you can help them understand their diagnosis better. You can help them decipher reality better, and just get back on track, man, because it's very much needed. You need people that care, because a lot of people, they just need that emotional support, and they definitely need someone that can properly assess their issues and point them in the right track, get them on the right medication, and help them become productive members of society once again.
So for many of us, considering a career, work-life balance, particularly for a physician, is often an important consideration. And when you think about working with justice-involved persons, for good or for bad, there's a greater ability to make one's own schedule, because the person in a justice setting generally is available to meet with on schedule. Typically, psychiatrists working in these settings aren't on call or have a minimal amount of call, and are afforded more flexibility in terms of work-life balance. In the next video, we'll hear from Dr. Lang and Dr. Oliveira about the achievable work-life balance that's possible when choosing to work with the justice-involved population.
I think personally for me, it's being able to maintain a healthy work-life balance. And that was something that was really important to me going through medical school and residency and putting in all those hours in training. I really wanted to make sure that after I got out of training that I still had some time to myself. I was able to pursue my own personal interests, fitness, literature, movies, music, and have the time to do those things. Working with the justice-related population, it allows me the flexibility to pursue those interests, but at the same time satisfies the professional needs that I have.
In the field, the time frame in terms of work can be much more flexible. There are most of the jobs, there are no calls. So you can have a better personal life plan, family, vacation, whatever you want to do in terms of your life.
One of the things we want to address here is getting exposure in some experience in working with justice-involved persons, in part because having a preview of a job experience often is a helpful way to choose a career. Unfortunately, residency programs in psychiatry have a variable amount of exposure to justice-involved populations, in part because the ACGME requirements for forensic experiences are not very clear and don't provide as much guidance as they might about what the requirements might be. Ultimately, site visits, working in courts by completing assessments and evaluations, and becoming exposed to working with professionals from the justice system are some ways that can increase exposure to working with this population. Advocacy from residents and early career psychiatrists for their own education is also important, and one important thing that residents and early career psychiatrists can do is seek out elective experiences to get greater exposure with this population. In the next video, we look at training recommendations for forensic psychiatry residency and fellowship programs, as well as suggestions and advice for current residents and early career psychiatrists from practicing psychiatrists who work with justice-involved populations.
It can be difficult for medical students and residents to find a rotation or an experience with somebody within their training area.
Most of the time, the clinical rotations that involve forensic settings are very short in time, and the psychiatrist or the medical student or the psychiatry resident is only involved in doing treatment. They are not involved in doing the forensic evaluations. They don't even get a chance to observe the forensic evaluator.
Residency directors don't themselves necessarily have that as their focus or their interest unless that's kind of who they are and what they've spent their professional life developing.
But I really think that early career psychiatrists at least start off with getting some sort of experience in it, however you can. Electives when you're in training, kind of moonlighting or whatever.
I think it's really important for people to see places. I'm a big believer in site visits and seeing where patients have been and how it would be to think about sort of what their experience has been.
The advantage of the medical schools having those kinds of electives or rotations, it provides not only an opportunity to train psychiatrists and medical students to work in such environments, but it also exposes them to the environments.
And I think they should be exposed to that as soon as possible in their training so that they can understand what are the legal concepts, what kind of things in terms of the mental health symptoms can affect their patient in the criminal justice system. So having more exposure, more elective time, and not only teaching them about the medical concepts, because we get that in medical school, we get that during residency, but also formally teaching them about the law, about police records, what they mean, how can they get access to it, is essential for a full understanding of their patients.
All these systems came into play and the different ways that they operated, the different needs of those different systems, the different mentalities that they bring to managing the same set of people that we were thinking about clinically. It was a very important experience in terms of understanding how they worked individually, how they came together as a bigger criminal justice system, how to communicate with those different parties, and ultimately how to navigate that environment with all those different agencies and individuals and parties at play to still create a setting that made clinical sense. So that was all very important coming out of real-time experience that I think can't be gotten simply by reading about it or spending a little bit of time going through, as a trainee. It was the experience of having to be an attending psychiatrist and making decisions and navigating those relationships was really, I think, invaluable in terms of understanding the system and helping me develop the approach that I have to non-clinical work now.
And I honestly think, looking back on my own career, if I had started there, if you can learn how to get people in a correction setting better across that full array, then I think there's nothing that you would see on the outside that you wouldn't be equipped to handle.
I think that's absolutely critical for both the program directors and the trainees to kind of seek out and kind of build those relationships with anybody that works in forensics or does any type of justice-related work.
Here's where I think young residents who are interested in the field can ask for experiences that they think of. Another thing that I've seen is that residents come up with their own ideas of wanting to gain exposure to something. And there's always elective opportunity that can be built into the program.
As soon as they have a hunch that they would like to work with any patient population involved in the criminal justice system, start getting involved with that population. Volunteer. Ask their program directors to have electives in jail, in a court, in a community setting where the patients are involved in the criminal justice system. Ask about it, read about it, talk to your supervisor. Not only take the information that they give you, question what you're doing and what are the legal reasons of what you're doing and treating your patients. And you get to understand patients more because you will see their experience that they're having with the criminal justice system, how it affects their life, how it affects their mental health symptoms, and you will be able to better assist them in the future.
Nothing replaces the actual hands-on being in the environment, seeing what it's like, and getting a true experience. And I know that it's not possible for all the medical students and residents to get into every aspect of the forensic work, but just to get a little taste of it, just enough to see maybe the didactics didn't give you a true sense of how it really is, or maybe you had some of those preconceived notions about what forensic work looks like or what a jail setting or correctional setting maybe you like to work in.
Without the experience, what people are imagining is not necessarily reality.
Exposure to settings, patients, and mentors, I think, are some very key components to helping inspire young professionals and helping educate young professionals who might choose that as a career path or who might treat people in other settings but need to know about that in their backgrounds.
So another important aspect of working with this population, aside from the pure forensic experience, is also gaining greater exposure to cultural competency and social determinants of health. The next video discusses some of the social determinants and cultural competency issues that are inherent in working with this population.
This has to do with the criminal justice system. When you're part of a minority group, even though you're not more likely than if you were in a majority to use drugs or to engage in drug-related crimes, you're a lot more likely to be arrested or incarcerated or be put on parole or probation for a drug-related crime. And when you're in that position, you're a lot less likely to receive treatment for addictions. And if you do receive treatment, you're less likely to receive evidence-based treatment for addictions. It's going to go on your criminal record, which is going to make it a lot more difficult for you to get housing, get all sorts of welfare programs, get employment, which is going to make your living situation more difficult. And if you have a history of addiction that's not well treated, you're very likely to either relapse or engage in selling drugs or other kind of criminal behavior. So in residency training, I think people need to understand why the social determinants of health are a major contributor to the maintenance of involvement with the criminal justice system and the maintenance of the disease burden.
You have a greater sense of where people have been in their own life and in their own kind of road to self-improvement and recovery and the things that you're working with them on as a psychiatrist, even if you're ultimately not going to work in a setting that focuses on that justice-involved population. You know, when I work in the emergency room and I do a shift, it's not uncommon to see somebody who just got out of a prison or who was brought in by police. So to have that understanding of what they've been through really is important.
In a community setting where a lot of the the patients that I had were involved in the criminal justice system. They didn't have the resources to get treatment, pay for medications. Their lives were quite complicated. So I saw how the criminal justice system can affect their life completely. And having a knowledge about that helped me understand them better, be more creative about treatment options, and also help me analyze and look further, not just the symptoms, so what's going on with their lives. And having forensic knowledge and doing a good forensic evaluation could help them solve their, problems with the criminal justice system.
I think that working with the justice population gives you immediate access to just vast amounts of their life, and you have to have an immediate rapport with somebody because there's so much on the line. They might be facing some legal challenges, they may be dealing with some social challenges that brought them into jail, homelessness, family abandonment, all kinds of different issues that you have to hurry up and have a grasp of because those are the things that they're going to ask you to address.
As I kind of got out of my residency training and moved into my career in more community and public psychiatry, it started off with really providing an integrated treatment team where you were addressing, not just their medication needs, but what were their social skills needs. Did they need housing? Did they need employment? Did they need access to food? Did they need access to benefits and whatnot?
So, they may not have money to have someone help them around, but if you have a little bit of knowledge about resources out there in the community, the hospital or other agencies that may be able to help this person. It's not just about the medication or the therapy. They may not even have the time to sit down with you for therapy for 30 minutes in a week or even 2 weeks. But knowing about what's out there available for them may be helpful for yourself and for the patient. So maybe offering this patient, there may be some services where someone, where they can get their laundry done for free, or some information about a food pantry, some free legal counsel, things like that you may incorporate into your treatment may help this person, their stressors, and ultimately their mental health.
So the final video talks a little bit about mentoring. Mentoring is really important aspect of choosing a career in that it provides some career advice and a reality check about work and what work conditions will be like. So let's look at this next video that illustrates the importance of mentors and the importance of seeking them out.
I also think it's really important to be exposed to mentors. I would not have taken the path that I took in terms of my career if I had not been exposed to mentors who helped me see the value, the interest, the intellectual rigor that goes with thinking about policies and practice with justice-involved individuals.
I was fortunate to have several great mentors who've really shaped how I think, how I talk about, how I think about issues around the criminal justice system.
I was lucky enough to have 2 different mentors, but both of them provided me with just such a wide range of experience and wanted to make sure that I saw everything in the field. And that was really something I owe them a lot. Having access to those different types of experiences, those different settings. I know we're talking about justice-related populations, but there's so many different aspects to those, different settings that you can practice in, different evaluations you can do, different types of treatment. Just getting an idea of what those entail was really valuable, and I'm very thankful to them for that.
Working with mentors who've been in the field, who are connected to people in different fields, who've worked with the criminal justice system, helps you, one, go over your ideas and then figure out what works and what doesn't work. And it kind of teaches you a lot of, you're learning humility from someone who's been in the field for a long time. You see someone who you've always thought of, this person is the smartest person I know. This is someone whose book I've read all my life. And then to see them interact with the criminal justice system with a lot of humility, to see them interact with prisoners, to see them interact with people who've committed terrible crimes with a lot of humility, is a great advantage. It teaches you to kind of be a better person in general and a better doctor.
You don't have to know in exacting detail a project that you want to work on. Rather, if you understand what you are interested in a broad domain, that can help you in an interview, and that's what you're really doing. You're interviewing people who might become a mentor. You're interviewing organizations that you may join as a resident. You're interviewing people who you might join as a fellow in forensic psychiatry. And so the more clear you are about what you want, that immediately elevates you in terms of any competitive advantage, and it will make so much easier an individual to say, I would be delighted to work with you.
So finding a mentor is a challenge, and I would say I've had many mentors in different ways. So one is, early on as a resident, you sort of look around and see, oh, I want to be like that person when I grow up, or I might want to dabble in what they're doing. They seem to have an interesting career. And then asserting yourself is part of it. And I find young residents, and myself, it's hard to knock on someone's door and say, can I have a conversation? You don't know if you're allowed to do that. I know I have not spoken to a single psychiatrist of my age or even, or older who wouldn't welcome somebody knocking on their door. So I think younger professionals, early career psychiatrists need to be encouraged to knock on a door for somebody that they've seen in the workplace that's interesting to them, or that might have a career that makes them kind of curious to learn about it. I also think that there's networks that are available to people. For example, in the American Psychiatric Association, there's mentoring networks that you can tap into. The American Academy of Addiction Psychiatry has mentoring networks. The American Academy of Psychiatry and Law has some networking opportunities. We started the Women of the American Academy of Psychiatry and Law for young women who are interested in forensic psychiatry, many of whom are interested in correctional psychiatry, and in fact, many of whom are working in correctional environments. So there are organizations that are natural networking environments. I look forward to these meetings. I have a friend group from all over the country, and so my mentors have not just been people more senior to me, but they've been this group of colleagues that I sort of established over my lifetime, really, of seeing people on a regular basis, hearing what each other are doing, and then tapping them and so your mentor doesn't have to be somebody older and wiser. It can be somebody that you've sort of grown up with and has now gained their experience themselves, and you can bounce off each other.
So, one of the important aspects of trying to address psychiatrist shortage and maldistribution is finding other programs such as loan forgiveness that would address some of these shortages. And one of the things we want to recommend is that in addition to the existing student loan forgiveness programs and the identification of physician shortage areas, we also maybe think about service to this population as a place for enhancing financial incentives and beefing up loan forgiveness programs or other incentive programs for this population. But I do want to conclude that, when people think about careers, often they make the mistake of thinking of a career as a single thing, as a sort of you pick a career, I'm going to do this or I'm going to do that. And I think for many, many people, what happens is they try something. And what we hope we've accomplished in this webinar is to introduce this idea of working with this population a tribe. And for those of you who have some trepidation, maybe you don't jump in initially with both feet, but take a job part-time or for some portion of your time at least, and give it a try. And I think those of us involved in this webinar think that it will lead to immeasurable rewards.
I think the value in psychiatrists having exposure to the population, to developing a deeper understanding, is not just in necessarily coming to work specifically in a criminal justice setting, but also if they're going to be community psychiatrists or clinic psychiatrists or even acute care inpatient psychiatrists.
So I encourage early career folks, think of it, if it's not going to be kind of your life mission, think of it early on, because I really think it's going to make you much better at what you do afterward.
But that those things that we learn about just to be good doctors and good psychiatrists are still fundamentally the most important thing.